All right, so good morning, good afternoon, everyone. I wanted to just start off, we'll certainly welcome our speaker in a couple of minutes. I also wanted to start off with some announcements because there's been a couple of changes to our seminar schedule. Here, let me pull that up for everybody. Okay, so I think you can all see it here. So this is the new updated seminar series. So the more new seminar schedule, which I'm going to ask to be distributed via email as well. So as you can see here, we're up to our second talk of the series. We had an earlier one from Amelie back in September. We actually canceled the November session has been canceled because it turns out two of the speakers we had initially invited um, were actually a part of the same lab. So we decided to combine, give a joint talk or a more unified talk in February from the Decipher lab with Tom Spencer, Kelly Dieterin, and some of the trainees in their group. In between, we have Einat Liebenthal speaking on December 13th, which is also it's 1 week later than initially planned. And we have a talk in January from Matt Knorr. And we added another talk in March from some of our early career investigator discourse members. So we all have this to look forward to. And then, as of course, for anybody who was here previously, you might know that we'll be hosting our now annual discourse satellite meeting together, co-located with the SIRS meeting, the Schizophrenia International Research Society meeting. And this year, that meeting will be held in Chicago. So SIRS will be March 29th to April 2nd, and the Discourse Satellite meeting is planned for April 3rd. And it's going to be located close to, not in a different city, but actually in Chicago. And it will be hosted by Professor Vijay Mittal from Northwestern and some of his colleagues, and it will be held on the Northwestern Medical School campus. So we're very much looking forward to that. As well. And then, so Lena, do you have any other announcements before we start introductions and all that?
No, you covered everything, Sunny. Everybody will get some information on newsletters about this first satellite meeting. That'll happen real soon. We'll have a first announcement in the next couple of weeks.
Well, so Lena, do you want to do your version of the introduction? I bet that's
Sure. Excellent. So thank you, Sunny. Well, good morning, good afternoon, everyone. It's great to continue this series. I'm particularly excited and really looking forward for today's talk. This is going to be on advanced diagnostic aspects of speech and language. We've been talking a lot about within psychosis implications of speech and language. Today, we're going to look outside of this as well. And there is no other better speaker than Emery. And Emery is one of the founding members of the discourse. We've been working on this steering committee for 3.5, 4 years now. And Emery is particularly suitable for this particular question because he's been working on transdiagnostic issues in bipolar disorder, in autism and schizophrenia for many years now, even before language work was started. Emre has been working on cognition and neuroimaging. So Emre Bora is a professor in Izmir in Turkey. He's working in the Dokuz Eylul University. He's also a psychiatrist who manages a large psychiatry department with very much clinical activity on a day-to-day basis. And he will tell you more about his clinical work and his findings soon. Emery has a very interesting track record. He's published very well in this area of speech and language, but also related areas in neuroscience. He did a few years of training at Melbourne Center for Neuroimaging with Chris Pantelis, if I remember that correctly, Emery, and still continues to collaborate very widely across the continents. Well, is there any specific information that I missed from the briefing, Sunny, that you have?
I minimized that window, so I am not
No, this
sure, but that sounds pretty good. Emre, maybe you can tell us if we missed something.
Emre can tell us more. Thank you. Over to you, Emre.
that I'm sharing. Okay, and thank you for this kind introduction. And I'm quite excited to be part of this course. I think it's quite important. And just let me talk about my city. I live in Izmir with a population of 4.5 million people. I'm telling you to understand the context there. I mean, I'm part of Dokuz University psychiatric and bipolar disorder programs, and also closely collaborating with child and adolescent departments of 2 public universities in the city, and for my old age work for neurologists. Also, I established the first early intervention program in Turkey. It's called ETAP, and the program has 3 main areas of interest. One of them is the usual thing, the early intervention for psychotic disorder and bipolar disorder in neurotypicals. It includes ultra high risk for psychosis and bipolar disorder and first episode patients. And for this assessment, we conduct for bipolar and psychosis assessment simultaneously to every individual in this program. Also, I'm also interested in autism spectrum disorders and its relation with psychosis and bipolar disorder. Again, comorbidity between them, and we are managing such patients there and conducting research about them. Also, third point, I will not be talk about the findings much there, but also interested in developing dementia, neurodevelopmental disorders in the context of psychosis and bipolar disorder, and old age psychosis, this sort of thing. I'm also, we are also interested about this subject. Also, I run a lab called Social Cognition Affective Neuroscience Lab. Social cognition might be one of my main areas. And also, I would like to thank my students, their PhD and master students, who are very critical in conducting our research. Outline of my talk, 4 parts. One of them is overview of findings in schizophrenia, then schizophrenia and bipolar disorder, and schizophrenia and autism spectrum disorder. Last, I will be talking about accuracy of our findings in measuring formal talk disorder. When we have a high rating for formal talk disorder or semantic abnormalities in automatic computation analysis, are we always measuring the right thing? This is always formal talk disorder, or it may be mixed up with some other things. And very short introduction. I mean, since 19th century, a concept quite similar to what we use today about formal talk disorder existed, but Bleuler was very instrumental in specifically associating formal talk disorder with schizophrenia. Unlike most, I have that. Unlike most psychiatrists, I have a difficulty when I use the term FTD because I also work for frontotemporal dementia, and sometimes terms mix up for me. FTD is sometimes formal talk disorder, sometimes frontotemporal dementia. Okay, and how we measure formal talk disorder? In general, we can use general psychopathology scales. All of these scales has subscales for formal talk disorder. Also, there are more specific formal talk disorder scales. Some of them might have more linguistic focus, others more conceptual thoughts. And these assessments are based on clinical recordings of clinical interviews, field speech, or speech and research understanding, or combination of them. The most well-known, all of them, TLC, TI, TALT, and TLI. And I came to my university in 2016, but even before there was TLI was widely used in our department. Regarding factor structure, in theory, it's supposed to have 2 factors, positive and negative symptoms. But when we review the factor analytic studies, evidence more consistent with the factor structure. One of them is a clear negative factor, one of them is a disorganization factor, and third factor is different across studies. It includes different parts of components of components or different parts of positive form of thought disorder, and this part is not very consistent. And also depends on the tool used. Dr. Firos scale, for example, was constructed as a 4-dimensional scale. Okay, form of thought disorder is clinically important. It's a marker of poor prognosis in schizophrenia. It's a predictor of transition psychotic disorders and follow-up in drives for psychotic disorder. And when we compare social cognition or neurocognition or functional levels of psychotic patients with bipolar disorder, schizophrenia and bipolar disorder, generally we found a bit more problems in the former group. But this difference seems to be driven by the patients with schizophrenia group who has a poor prognosis and have a pronounced negative symptoms and disorganized symptoms, rather than a severity of psychotic symptoms. For example, if you look at this cluster analytic study of cognition is a transfrontal one, there was a one clearly cognitively impaired group, one of them has a near normal cognition, and clinically what distinguished the two groups was not the severity of history of psychotic symptoms, but it was the disorganized speech and negative symptoms in the cognitively impaired group. Okay, if you look dimensionally, is there a relation with cognition and linguistic measures and formal thought disorder, positive and negative aspects of it? In this meta-analysis of myself, Berna, and our colleagues, it was clearly shown that there is a significant relation between these concepts, but it's a modest relationship. Okay, semantic priming hypothesis, increased semantic priming, was particularly popular a few decades ago in explaining formal thought disorder. And I mean, we would expect as actually a decreased semantic similarity according to this theory. But the evidence is more mixed, actually. If you look at semantic priming abnormals in schizophrenia, first of all, effect size of the impairment is small. I mean, second, the people with patients with and without formal disorder was not significantly different in this matter. There was a bit more impairment in the formal disorder subgroup, but the difference was not significant. Of course, semantics is particularly interesting. And we must combine other methods with computational methods, such as electrophysical methods. Or if you look to the imaging and neuroanatomic correlates of these abnormalities, this coordinate-based materials shows that clear left-sided language networks are more in. There's a difference in the size in patients with formal thought disorder compared to the ones without. And if you look at the first cluster connected pattern, it's clearly there's a strong correlation between Broca area. I mean, it seems that the language network plays a role in formal thought disorder. But I want to remind you that the evidence is actually weak because, like it's all for brain imaging studies, only 6 or 7 out of 30 studies plays a role in this findings. In most studies, the findings were not supporting this hypothesis. I mean, the current technology for brain imaging has problems. I mean, we have Enigma other studies, but the effect sizes are always small. Of course, it's also possible to investigate linguistic anomalies with manual methods, with linguistic analysis. And for example, this one was conducted in collaboration with Dr. Profam Hinsan and Derya Chokal. And it clearly shows that patients with schizophrenia has an increased reference anomalies compared to healthy controls. This was already shown in other languages by Dr. Hinsan. And there's an ongoing paper and preparation with Derya with Wolfram again, and this time earlier stages of illness, first it was psychosis, ultra for psychosis, autonomic for psychosis. Similar abnormalities for referential anomalies are evident, and there is a decrease complexity in sentence structure in psychotic disorder subgroups. Okay, and just as regarding voice patterns, there is again quite a bit inconsistency across this one, but pitch variability seems to be the most consistent abnormality in schizophrenia, and it seems to be related to the flat effect, and its effect size is moderate. Of course, there's a large effect size for proportion of spoken time, speech rate, or duration of pauses, but yes, of course, our patients are speak less or short speech answers. The pitch variability is important. And it seems to be also cross-linguistic, the most consistent one. Turkish, we have similar findings. We are preparing a paper for them. And accuracy in a machine learning model was modest, like 74% in distinguishing patients and healthy. Okay. Since the pioneering study of Birita, I think people used many different methods to try to analyze semantic and other language abnormalities in schizophrenia. And, you know, there are many methods such as word-to-word, S-word, dealing with semantic similarity and related concepts. Also, other methods such as part of speech technique. And by these natural language processing techniques, it's possible to study discourse coherence, poverty of content, referential coherence, metaphorical language, and so on. And I mean, there are examples for each of them in for different stages of the illness. Turkish is different compared to most of the languages here. Its grammar is not an Indo-European one, it's the Ural-Altaic language. But it includes lots of borrowed words from Persian and also Western languages. I mean, the word content it includes many, but it's a grammatical structure, is the Ural-Altaic language, and not in the European one. But we found very similar result, and we found increased semantic similarity in the speech of patients with schizophrenia compared to healthy controls. Our machine learning was 87% accurate in distinguishes two. Of course, many people number of people use these methods in earlier phases of the illness, in first of psychosis or people at high risk for psychosis. And we published a recent paper in the clinical high risk for psychosis. Our findings were similar to chronic patients, actually. And this at-risk group demonstrated higher sentence levels, semantic similarity, and reduced mean image-to-text similarity. Also, at-risk group used a lower number of words and put shorter sentences. And the machine went up. It was 80% successful. We are, of course, following up these patients, and we will have follow-up data in the future. And our semantic findings were related to mostly to negative symptom ratings. But before moving on, I want to also to consider a few considerations. I mean, one of them, yes, we find increased semantic similarity, and it may seem at odds with the earlier hypothesis. But when you think that most of the findings of most of this reflect speech poverty in non-acute phase of the psychotic disorder, it might be expected. And this algorithm, current algorithms, might not be particularly useful for relapse prediction. They mostly based on stable patients. And the follow-up studies in different phases of illness are important. And the relapse prediction can have a clinical utility, therefore it's important. I know there are ongoing efforts for collecting data in different stages of illness, including algorithm. And also, there's a clear heterogeneity in our patients, and we need data-driven studies to reconstruct this heterogeneity. For ultra-high-risk studies, current algorithms might be sensitive in differentiating true positives from false positives. I mean, it may be thinking to predicting who will get ill, but don't forget these samples include many people who are not really in this truly in the schizophrenia spectrum. There are false positives there. But I'm not sure they will work for predicting transition to psychosis among true positive. Okay. When we talk about transdiagnostic work, bipolar disorder is always comes to our mind first, because first of all, there's a clear overlap, etiologic overlap, genetic overlap between conditions, and also clinically is important. When you consider someone who has a bipolar disorder, psychotic disorder, or who has a schizoaffective disorder, or schizophrenia with history of manic episodes, for example, clinically distinguish them is important. And objective methods will be welcome for sure. Okay, we conducted a mechanism a few years ago when we look at the form of thought disorder in schizophrenia and bipolar disorder. In the acute stage, for positive form of thought disorder, for in people within the manic episode and psychotic episode, they have similar level of impairment. But in stable period, of course, there's people with schizophrenia, you find more difficulties, more increase, more thought disorder there. For negative thought disorder, it's always in the schizophrenia group, there's a high rate. Very few studies have investigated linguistic abnormalities in bipolar disorders. This is one of the better examples and the good rare examples. And this study showed that both bipolar disorder and both schizophrenia is associated with impairment at the level of comprehension of sentences. In the narrative protection, bipolar disorder, there's a mild impairment. But up to today, natural language processing methods used in bipolar disorder in many studies, but their focus was different. Mostly they applied to social media and electronic health records. I mean, people gathered electronic health records of the past patient records and can we predict suicide, can we predict diagnosis, or Twitter messages, can we predict suicide, this sort of designs. Not so much type of experimental research, automatic language analysis that we discussed in first schizophrenia. But this is quite typical for bipolar disorder. So generally, when we study biomarkers, first we conducted schizophrenia, and a few years later, the bipolar people repeat this analysis, and this will be the same here as well, as expected. And lately, we published one paper which compared computational linguistic features in speech samples of first bipolar patients and first psychotic patients. And here, both groups use short sentences, and both groups have a increased sentence level similarity, but both groups have less semantic alignment with pictures. Only psychotic group had demonstrated reduced verbosity and syntactic complexity. And only finding which was more pronounced in bipolar group was increased use of first person singular pronouns. I know that few studies found similar finding in psychotic disorder, but for bipolar disorder, it seems to be even more pronounced compared to healthy as well. And classification accuracy between groups are as such. And if you look at mean local similarity, and bipolar disorder lies between psychotic disorder and healthy controls, and it significantly differs from healthy controls, but also from psychotic disorder. But if you look at mean image to text similarity, both groups are have impairments at a similar level. And we have data for chronic bipolar patients for ultra high risk for bipolar disorder and familiarized bipolar disorders, and we are conducting and we will be planning other papers from these speech recordings. I hope we will publish them in 1 to 2 years. Okay. The third topic, I will be talking about autism spectrum disorder and schizophrenia. I found this particularly important because of the neurodevelopmental nature of schizophrenia. Actually, number of studies have investigated formal thought disorder in autism spectrum disorder, mostly using one particular scale called KD formal thought disorder rating scale. It includes four subscales, which includes illogical thinking, incoherence, loose associations, and poverty content of speech. And one of these earlier examples, the researchers compare autism spectrum disorder with multiple complex developmental disorders. This concept was proposed as an indicator for early psychosis and the people at risk for psychosis or this type of disorder. And the thinking there is if formal thought disorder is related more related to psychosis risk, the people in the second group will have more formal thought disorder. But it was not. Both groups had a similar levels of increased formal thought disorder in this study. And these increased ratings were mostly related to autism spectrum disorder related communication problems rather than the increased psychosis risk. This one. Another study, again, recordings based on story game, based on the scale and similar findings, but this time the increased formal thought disorder ratings were related to pragmatic abilities. In another one, they were related to verbal word memory. All these verbal abilities related to increased formal thought disorder ratings in autism spectrum disorder. In this study, formal thought disorder ratings autism spectrum disorder predicts future symptom severity, but not psychosis program. Of course, it's a cross-section of psychosis program study, but okay, I think these are important in for schizophrenia research. I will come to that. But if you talk about the voice patterns, since Kenner, we know that there's a change in quality of voice in autism spectrum disorder. They have a more monotonous voice, atypical prosody, and phonation abnormalities. However, there is a large inter-individual variability. In some patients, as soon as the patient enters the room and speaks, you see some difference. In others, it's much more unnoticeable. And unfortunately, the current autism spectrum disorder scales has a limited place for assessing speech abnormalities. For example, the golden standard ADOS2, there's only one item, speech abnormalities associated with autism, and very crude measurements from 0 to 2. Or social relationship scale has only a single item 53, talks to people with an unusual tone of voice. That's all. But number of studies used automatic computation vocal analyzers, and there is a meta-analysis for them. And like schizophrenia, increased variability of speech is evident, and effect sizes are similar. It seems a shared finding, but increased mean pitch is also evident in autism spectrum disorder, unlike schizophrenia. There are some studies with very young kids about vocalizations. They may also play a role in diagnosis in the future. Regarding somatic abnormalities, there are very few published studies. In this particular one, actually, authors found decreased semantic similarity of the spectrum disorder compared to Candida. Also, there are attempts to combine automatic voice measures and automatic language measures, and in this particular study, it's shown that combining them had a better accuracy compared to using only one of them. Okay, I will be talking about our primarily findings, which compare autism spectrum disorder and schizophrenia in adults. We use here sentence similarity measure SPER and word similarity measure word2vec and sentiment analysis based on a Turkish Pretend sentiment model. If you look at local semantic similarity, both groups, both schizophrenia spectrum disorder and autism spectrum disorder, there was an increased sentence similarity, local and global level. But if you look to local word similarity, only autism spectrum disorder, we found an increased word similarity. In the sentiment analysis, people with both patient groups use more negative words with more negative sentiment. For positive autism spectrum disorder, use such words less. We are still working on correlation and other things. I mean, we are interested to see their clinical correlates because all of these patients have assessment for psychosis risk or negative symptoms, or also autism dimensions with clinical interviews. And are they related to, in autism spectrum, are they related to autism or psychosis risk? Also, we have, not this, but we have data for people with autism spectrum disorder and comorbid psychosis and without psychosis. Comparing them will be, I think, quite interesting. And we are interested to work more about cognitive and social cognitive correlates of such findings. Okay. My last point will be about looking a bit more critically at what we are working. Okay. Because schizophrenia is a neurodevelopmental disorder, some people might have problems at the premorbid phase. Developmental pragmatic language difficulty is one of them. And general verbal abilities and cognitive impairment before the onset of illness, when you are a child, is one of them. And education is also plays a role. Also treatment effects such as antipsychotics, they may cause secondary negative symptoms and might play a role in the decreased verbal output. I wouldn't be talking about older patients today, but in the older samples, the effects of prodromal neurodegenerative syndromes and their earlier signs and increased vascular load, they also might have an impact on our methods. And all of these factors may influence our formal total disorder ratings as well as our computational analysis. And the cognitive impairment is mostly neurodevelopmental in nature inside the disorder. And this is important. Also, cognition, executive functions, pragmatics, and social concepts, they are related but independent concepts. And that it's important to look at the high risk. If you look to Danish high risk study at age 7, the children who have a high risk for psychotic disorder already have language abnormalities and social cognitive abnormalities. Okay, just I want to remind you the differences and about social cognition and neurocognition between autism and schizophrenia. Recently, we published one meta-analysis on that subject. If you look at non-social cognition, the people with schizophrenia are more impaired, both in 6 cognitive domains and as well as in IQ. But in the older samples, the difference is increased, but in the younger samples, there is less difference. If you look at social cognition, as a whole, there is no significant difference. But if you look at younger samples, I mean, here, younger than 25, of course, there's no children's survey, because they don't have the diagnosis yet, psychosis. Then social cognition more impaired in the young. But I am sure if you look to the children, for example, take a 7-year-old child with autism spectrum disorder and take a 7-year-old kid who will be schizophrenia in the future, all of social cognition, all of the language abilities are more impaired in the autism group. I mean, their trajectories are different. But it's relevant for schizophrenia research. Because people with autism have a 9 times increased risk for developing psychotic disorders at follow-up. And more than 10% of people at risk for psychosis have a comorbid autism spectrum disorder. And many people with schizophrenia might have a broad autism phenotype or increased autistic traits. For example, we are preparing one meta-analysis, and it's clearly short with a large effect size, 1.3 effect size, increased autistic traits in schizophrenia. We completed one large study investigating the autistic dimension in schizophrenia. I think you may consider like 20% of the people with psychotic disorder have autism spectrum disorder or broad autism phenotype. which precedes the onset of the illness. Then it means that there's a sizable subgroup of individuals with schizophrenia who have the history of autism spectrum disorder or they have a broad autism phenotype. These people have developmental pragmatic and social cognitive abnormalities many years before the illness, and they have a decreased verbal abilities. In autism spectrum disorder research, data shows that FTD ratings are increased due to pragmatic abnormalities and poor verbal skills. And for this subgroup of patients with psychosis, it will be the same. And this might be also a problem for computational linguistics. We must look at these factors more closely. Okay, my final words, I just re-emphasize Tayal's diagnostic approach. Not just bipolar disorder, depression is also important for negative thought disorder, and other diagnoses are important. Dimensional research is of course important. And we may need to collaborate for large data sets or data-driven studies for deconstructing heterogeneity of speech data. And we need to take into consideration a neurodevelopmental perspective in understanding speech abnormalities and how we deal with them and how we measure them. And I think it's not just autism spectrum disorder, but it's the prevalent one. And of course, there are technical, they are in early days, and there's a need for further refinement in large language models for objectively assessing for mood disorder, thought disorder. And it's not relevant anymore. And this is all. I want to thank you all. And I would like to hear your comments or your contributions. Thank you.
Thank you so much. Thank you. That was great and very on point for our planned symposium submission to SARS as well. Lena, I see you have your hand raised.
Yeah, thank you, Sunny. Thank you very much, Emre. I really enjoyed this talk. Really broad overview of autism and bipolar and a lot of things that we haven't discussed before. So thank you for putting this together. I was particularly intrigued by one of the observations that you showed across the diagnosis. It is on semantic similarity. You did show the bipolar folks have very similar values to the first episode psychosis, but in autism, the difference seems to go in the opposite direction. So I have a couple of questions on that. Number one, do we know anything about the developmental pattern, age-related pattern of semantic similarity? Number two, how do you link this with what cognitive construct do you link semantic similarity in your work with? Is it with something like perseveration, for example? We do see perseverative errors quite a lot in schizophrenia and autism as well. But if it is related to perseveration, the opposing directions seem to be a little bit contradictory. So I would really like to hear your thinking about what is lying behind the semantic similarity.
Okay. Of course, we may speculate, but I think the measures we use, such as semantic similarity, increase, decrease, are very simplistic, and they may mean different things, but the way we analyze them might be causing this overlap. And also phase of illness. I'm not sure any of them. For bipolar disorder, if you measure them during manic episode, I'm sure the results will be very different. And actually, we need this sort of state-related changes, and they might be more relevant for clinical use. But for increased semantic similarity, I think it's mostly related property of speech at this moment. And perseveration, I think, plays a secondary role, but also plays a role. For autism spectrum disorder, there are only a few studies, and it's also heterogeneous. I mean, I'm looking forward to, even from my own data, we have data as autism spectrum disorder with psychosis. I'm very curious about how it will be compared to autism spectrum disorder without psychosis and psychosis disorder. Autism spectrum disorder is also, okay, if you look to CMV studies, there are deletions and duplications. Some of them deletions increase the risk of psychosis, opposite increase the risk of autism spectrum disorder. But the same one which increases the risk of psychosis also increases risk of autism spectrum disorder. Some autism spectrum disorder are related to increased psychosis risk at follow-up. Others decrease the risk of psychosis at follow-up. It's a very, I think, exciting area, but I cannot answer your question as a whole as autism. I'm not sure. We need more experimental data for it.
Wolfram?
Mm-hmm. Yeah, thank you, Emre. I have a similar question about syntactic complexity. I think you mentioned that the bipolars were different from the first episodes of psychosis in syntactic complexity, if I remember correctly. And I was just wondering how that is measured in that study. In many studies, syntactic complexity is kind of measured by proportions of parts of speech or something like that.
Yeah, same.
And I've never understood why that is a good measure of syntactic complexity. So I was wondering what measures were used.
Yeah, I agree. Same. I mean, they have the. Also, yeah, I agree with you. I mean, we have to look it better. But also, bipolar disorder is heterogeneous. If you look it in a more nuanced way, I mean, for example, if you look to people who have a poor education results at high school, they have increased risk for bipolar disorder. And if they have a better scores, again, they have increased for bipolar disorder. And these two groups might, for complexity of syntax, they might be just opposite in reality. We just combine them.
I see. Right. Yeah, so there is a couple of problems there. I also have a more general comment about the transdiagnostic investigations that you are making. So I think you're approaching this quite in a data-driven way. So just looking which patterns generalize to other disorders and which do not. And I was kind of wondering from a more hypothesis-driven point of view, what do we actually expect? And in particular, Lena and I, for example, have argued for this transdiagnostic L factor, which we expect to describe all diagnoses that come broadly with a cognitive decline or a fundamental cognitive change. So from the viewpoint of that paper, we actually do not expect a lot of specificity for a lot of the linguistic measures we are using because there is fundamental cognitive change. Cognitive change in each of these cases, and from the viewpoint that language and cognition are highly integrated, we would not expect that you find one disorder without linguistic impairment and another disorder with linguistic impairment.
I am not sure about that. I mean, I will make a counter argument there. I mean, different ages have different trends, and last 10 years, we talk about transdiagnostic concept, but we must look at it critically as well. I mean, of course, there are no simple categories and there are real transdiagnostic concepts, but most of the transdiagnostic dimensions may be fake transdiagnostic. If you don't measure things well, all things look similar, and you give 10 something, 3 to something, but they may be completely different thing, and then we are causing lots of transdiagnostic measure signal ourselves as well. I think both have true. I think there are some real transdiagnostic language and cognitive domains, but there are different ones as well. I think I'm not sure that there is a single transdiagnostic language concept which can across the outside. I think we will have a more nuanced.
Okay.
Add something to that. I can't help thinking, Emery, when you answered the question, we got to go back many years to think of Kraplin's approach as well for transdiagnostic resolutions. It's longitudinal, it is trajectory. Unless we understand how things emerge and evolve, it's going to be really challenging for us to do cross-sectional comparisons and conclude if there is anything specific or if there is anything distinct. I say this because some of your data, like how syntactic complexity changes with phase, how semantic similarity changes with acute versus chronic. These are very telling. These may not happen in a similar way in all disorders. We don't have enough data. And I come back to the same thing that you mentioned. We don't have enough data to conclusively say, do we understand these patterns or not? If all of us could put some longitudinal data on the table, we will have different kind of questions to ask, I think.
Yes.
I wonder if some of that underlies why, Emre, you pointed out in one of your slides that you didn't feel like these types of measures would be useful for relapse prevention.
Yeah, because but we can develop such measures. I mean, at the moment, most of the speech recordings are conducted in relatively clinically stable individuals. There is some variation with people with more, but I mean, they are mostly the people who talk less. But if you look to when they increase psychotic symptoms or may have an increase from, I think some of the people will have a less semantic similarity. Some of them even have a more semantic similarity in the psychosis, and we need to look them longitudinally at different phases. And it's for bipolar disorder. It's particularly important.
I think working across many different languages also, I think, exacerbates the issue of having enough data, and not just in terms of the results, but perhaps in the methodology as well. I know that you've used some LLM, you've implemented some LLM-based analyses in Turkish, and I wonder what that experience was like and whether it was, whether there were any difficulties in terms of using a language that's less well represented in NLP.
Okay. Mostly we done this work with my PhD students. They may be also listening here with Elif as well. But I think it went better than we expected. Despite the fact that, for example, Turkish Wikipedia is smaller compared to English one, but still we found relatively similar findings compared to English.
Our model based on an SBIRT pre-trained model, which is multi-language, which includes multi-languages, and one of them includes 15, and other one 50 different languages. That's why it's not specific to Turkish, and this, of course, might cause some problems. We tried to use Turkish specific models, but we couldn't find the SBIRT model was much more better. We thought that that's why we implemented, and yeah, maybe this might cause a problem, but that's what we have, and maybe we can contact some of the collaborations with some universities in Turkey. Yeah.
Thank you, Elif.
You're welcome.
And then Lena, I see you shared something in the chat.
Yeah, it's a really shameless plugin. This is work looking at clinical high risk, acute psychosis, untreated psychosis. This is to the point that Emre made. We don't have lots of untreated acute psychotic data, but this particular study, we have this from the first 3 days of presentation in patients. And what we see is the higher semantic similarity is actually related to the phase of the illness, much more than diagnosis per se. Now, this is not longitudinal. I wish we have enough longitudinal data to say this with confidence, but cross-sectionally, it looks like the acuity of psychosis has something to do with semantic similarity.
Well, if there's no other question, maybe I'll wait one more second. People can feel free to still raise their hand, but if there are no more questions, then fantastic. Thank you so much for a really enlightening talk. And I look forward to hopefully getting to hear some more when we're in Chicago. We're hoping, just for everyone else, we're hoping to submit, we're hoping to submit a symposium organized around the concept of cross diagnostic as well as distinctive speech and language models across different disorders. And Emre is one of the speakers that we're hoping to include as a part of the symposium. So fingers crossed on that one. And thanks everybody for joining today, and have a good rest of your day.
Bye-bye.
See you next time in December.
Okay.
Take care.
Bye.